what I'm a little, the decomp patient is a little bit different, I think, than the patient, maybe to my mind, a little different than the patient you were speaking about. How do you advise about the diet? This sort of, how do you approach the diet in somebody with decompensated disease versus the patient with compensated disease? Is it no different to you? Or is there sort of some special requirements? I mean, their diets are already restricted, right, in many ways, with salt and other things. The reason I'm asking is that I worry a lot about like loss of muscle mass. They're sometimes not very mobile, so how do you counsel about a weight loss program for somebody with decompensated cirrhosis versus compensated?
So I think it's a great question, and first of all, we have to remember fluid. So weight is of no value here. We have to use means of assessing the obesity in the first place, which has to be in these patients to look at their body composition. Because if you don't look at body composition, you really don't know what you're doing as you do these things. I don't worry as much about muscle mass because muscle mass is overrated as a predictor of anything except for mortality. Well, that seems pretty important. Mortality is kind of important. But you're getting at mortality. You're not getting at effectiveness of weight loss. So I think we have to be very careful about the mortality is not from the weight loss. The mortality is not from the obesity. The mortality has to do with inanition, which is a different situation entirely. Most of these patients are at risk of even as they have obesity, they're at risk of inanition at the same time as they have obesity. So that you have to watch out for. However, there's no evidence that the type of diet that somebody is on actually prevents or promotes that. It's been talked about for 50 years in the literature, but there's very little good evidence that makes a difference. So in our hands, what we want to do is we want to get the safest weight loss possible. And that's why I'm moving more and more toward medications where you're not trying to manipulate the food intake. What you're trying to do is manipulate the body's regulatory system so that then the food intake is ad libitum. We don't tell people to eat less. We just say, if your body wants to lose weight, it'll lose weight, and anything we can do to do that. That's how bariatric surgery works with respect to what's in the literature. Bariatric surgery works by changing the body's regulatory. The restriction of malabsorption are side effects, but they're not the main drivers of the way surgery causes weight loss. So we want to use things that drive weight loss, and we want to drive weight loss as, quote, physiologically as possible. And the easiest way to do that, I think, is medications rather than lifestyle.
So in a decompensated, so tell us about the safety of the medications in somebody with decompensated disease too. That's the other piece to this. So it sounds like a decompensated patient, you might go to medications earlier.
Right.
So then if you could just maybe go through,
So
more like what should we not use?
Right, so you have to be very careful about metformin because metformin is obviously a concern. What we don't know, let's start with what we don't know. And I think this is for anybody who's in the audience or anybody anywhere in this room who might want to study this, is if you treat a patient with, say, bariatric surgery or with a medication, and then they get a liver transplant, what actually happens to their physiology? Because now suddenly you're putting an effective liver in between the cycling of all the metabolites. We don't have a clue about that. So the first answer to your question is we don't have a clue. But phentermine is a drug, it's an adrenergic drug, not cleared by the liver. It's actually an old, 1959 it was approved, an old, inexpensive, effective drug. It is adrenergic, so you are going to increase some cardiovascular risk, but it's a mild increase. We use it in people with hypertension. We don't use it in people with tachyarrhythmias. We don't use it in people with decompensated coronary artery disease or cerebrovascular disease. So that's a good drug. Topiramate is a drug that's mostly cleared by the kidney. So again, it's a drug that we can get away with in decompensated liver disease. There is some liver clearance, but it's not very much. The biggest risk is peripheral neuropathy and cognitive dysfunction, but if you load it slowly, it's not a problem. And we've been using it for 30 years for treatment of migraine headaches, and nobody's been complaining about it. So I think it's probably reasonably safe. No drug can be considered safe at the start in decompensated cirrhosis, as you know. So those are the two that we would most use. We might use we're not using it as much now, but I can imagine in the future we'll use GLP-1 agonists. We're using them more and more. They're very effective after bariatric surgery in that combination therapy in the top bar that I showed, and I think that they may have a very good place in decompensated liver disease, but there's no data yet published.
I just want to do a quick poll in the room. How many have actually prescribed a weight loss medication? Okay. In decompensated patients? Okay.
Yes.
So, yeah, no, but that's why I think, it's informative here, because I think there's a spectrum you highlighted that I think very well. So a cirrhotic who's got cancer is their primary indication for transplant, that's probably an easy scenario, but it's the decompensated patient I think is a challenge for us.
Right, exactly, because it's the sarcopenic obesity, and in the setting of a catabolic state that would be really concerning in a decompensated patient. So, if you think sotropyramate would be safe enough to try, for example.
Yeah, and this idea, and the reason it's a registered label, safe use protocol, is because that's the thought. The thinking is we're going to kill everybody. That in our zeal to treat obesity, forgetting about liver disease, we're going to just go around killing everybody with these drugs. And again, we talk about bupropion, which again has metabolic effects. We've been using it for 40 years for everything all the way down to smoking cessation, and it's not been considered an unsafe drug. Suddenly it's an unsafe drug. I think that decompensated liver disease raises the bar so high that these things have to be looked at carefully. This is not something to be done in your basement. This is something to be done in a center where you can monitor things very, very closely. But if this is going to be the #1 cause of liver transplantation, we're going to be seeing these patients, and we'd like to get them through transplantation, and healthy again, I think we're going to have to seriously consider these things.
Please, Arun.
So great talks. First, a comment. I think it's really important that in the future we document the impact of the weight loss on the transplant outcomes, because that's why we're trying to get them to lose weight before transplant. We need to document that data. The second is, in context of bariatric surgery, particularly where the weight loss can be rather fast, are there data, Puneet, that you came across on worsening MELD? Because we know there, at least historically, if you lose weight very rapidly and you have marginal liver reserve, you can tip the patient into a decompensated state. And in a recent review, I think meta-analysis of all the bariatric data in the cirrhotic population suggested a 20% decompensation rate within a 12-month time frame. So can you comment on that?
I think this is a great point that you brought up in regards to the even low MELD score is not safe haven just to be able to tolerate a surgery such as a bariatric surgery. It's very clearly established that the surgical insult could trigger the similar DAMP pathway related decompensation, and we do not have adequate measures to assess the reserves for the liver function. However, most surgeons do not, and I think even including many consultants who are clearing the patients for their surgeries for bariatric surgery, even if they may appear like early child B, with maybe just ascites, but you factor in the Mayo risk calculation score as well as the LABE model, these risk of decompensation and death at 6 to 12 months are significantly higher. And unfortunately, those are not factored in at the time of risk stratification or assessment. So I totally agree with your point that there is a higher risk. However, the data regarding any such reports have not been clearly documented except in that meta-analysis.
So can I get you guys to speculate a little bit now on the use of a quantitative liver function test as a way to select those who might actually do okay and definitely not do the ones, who might get in trouble after such surgery?
Arun, just before we speculate on that, which is an important issue, we didn't talk about the efficacy, and you alluded to the meta-analysis. The meta-analysis actually puts a little more of a question mark on top of the efficacy. So not only do we have a safety question mark, we also have an efficacy question mark. And just as an example, we saw some data looking at complete resolution of diabetes or complete remission of diabetes, which is exactly what was said for non-transplant or non-fatty liver patients years ago, but now with the randomized controlled trials, many of which, at least a half dozen that have been published now, we know that full remission of diabetes in the larger population is only about 50% with a gastric bypass, 45% or 40% with a sleeve gastrectomy, and half of those 10 years later are going to see recurrence of diabetes. So, but we started by saying it's a perfect solution, and now we're realizing that that diabetes, by the way, is nowhere near as severe as it was before the surgery, so I'm not downgrading the surgery, but I think we have to look at efficacy. To your question, I'm going to defer to you on his question about the liver test.
Right. So one big other point that should be taken into account is that who is the right candidate? Because obesity for surgical indication, if you go by no comorbid condition, then the BMI cutoff is 40. Now, traditionally, this has not been included as a comorbid condition where 35 would be acceptable risk to undergo surgery. So my point, and this is not, it's just like a thought amongst the audience and also for discussion, is that if they have BMI more than 40, that is one big consideration versus one would be eligible to undergo or take the risk of performing bariatric surgery for BMI of 35 and above. Because recently there was a paper that came out from India that looked at the intragastric balloon as an option just to try to prepare them to undergo surgery. So it's a short course where they lost weight and that promoted or helped them perform surgery safely. Probably that was the only indication, but it did not have a long-term outcome effect. So optimizing the candidacy, probably that is one of the approaches, but I do not know on that cutoff range for BMI. Oh yes, it is. At this point, it is very early. And the quantification is very important to assess, and this will certainly be a study that can be performed with even multi-center if one were to plan. This is a very reasonable question.
Do any of you have experience with these?
No. Oh, there's a.
Do any of you have experience with the breath ID or with the collate clearance
HepaQuant
test or HepQuant or anything like that in this setting? But it seems like that's sort of a low-hanging fruit in this space that could be tested.
But don't you think that looking at like the severity of portal hypertension, that the severity of someone's baseline MEL score is still informative in terms of the risk for that decompensation? And I think, I always wonder if it's the type of surgery they undergo as well, because in our program, we actually are one of the programs that does sleeves pre-transplant and sort of A, early B cirrhotics. Interestingly, the surgeon who does that is also a transplant surgeon. You know, he does liver transplants and he happens to do sleeve gastrectomies, which is a very good situation because I think then he really knows how to assess the liver disease and understand sort of what needs to be in place. But he is most concerned about sort of severity of portal hypertension. And he's also concerned about just the degree of sort of liver synthetic function. He uses like simple bilirubin and albumin to really guide him. But I'm not saying that, the series that you showed is actually from UCSF. And so, it's 7 patients, what's that? Now we've done 20, but it's still 20. It's nothing really. So I think it's really an area where we could use some new markers of injury and recovery.
Well, I think we need markers, and we need to have markers that obviously, as is the Holy Grail, to look at the whole liver non-invasively at once. Right. I think you're absolutely right. We have to look at beyond liver synthetic function. We have to look at all the other components. We also have to go step up one level, which is we have to look at predictors of benefit and predictors of risk at the same time. And I think that we don't really, it's almost a data-free zone. My bias, I'll just say it because it's not the bias that's been expressed, is that if you want to prevent recurrent fatty liver disease, a gastric bypass is going to end up being far better than a sleeve gastrectomy. There are far fewer surgeons who feel comfortable, particularly in these kinds of patients, doing a gastric bypass. But the 10-year data in sleeve gastrectomy are starting to come out and it's starting to fall off the curve. So even though sleeve gastrectomy is about 80% is good for weight loss, about 80% is good for diabetes remission, it falls off as you get toward, between 5 and 10 years. So there is a real question. You're talking about people who are going to have a long life expectancy, you hope, and you might want to be doing the best operation. Again, a data-free zone. We just have to think about it.
Maybe Dr. Wiesner can go ahead and comment on this too, but also
I
there's
just
the
wanted to
issue of
comment on Nora.
immunosuppression.
Do you have a MELD cutoff
Yeah.
for your pre-transplant sleeves?
For Nora,
for
you said?
Nora, yeah.
Oh. Yeah, I think, basically, it's
And how many
individuals,
people have you tipped over that needed a transplant after?
to my knowledge, none, but, you know, what's interesting is they're all evaluated for transplant beforehand, because we anticipate we will, in fact, have that happen. It hasn't yet, but I think it definitely can, and I think it sort of speaks to, I think, what Arun is saying, and, you know, I think we're very cautious about who we do transplant. The sort of best candidates are that have, those that have had their first episode of decompensation and then kind of recompensate, and patients with cancer, where we feel like, you know, at UCSF, they're waiting a year and a half to get a transplant, so we've got time to sort of work through that. But honestly, I think we're very cautious, but there's they usually have males under 15, and many of them have lower than that.
So you wouldn't do this in a MELD of 28 or 29?
No, no, never,
No way,
never,
no.
never.
So we do this too, but we actually have taken, so patients who have at least radiographic portal hypertension, nobody who's got overt, you know, decompensated cirrhosis, but we've done TIPS prior to sleeve gastrectomy in many patients as well, to sort of get them through the surgical, you know, bleeding issues that are related.
But can we come back to the issue of the type of surgery? You know, your comment about sort of the long-term benefits, I understand that. I have to say, in this pre-transplant group of patients, I think we're quite worried about the malabsorption actually contributing to malnutrition, and ultimately to them, you know, getting sarcopenic and the whole, because, you know, that's an important marker of mortality. And so I think there's been a little
yeah.
reduction on our part to think about that.
And I think it's very important here's where there are some data. Gastric bypass and sleeve gastrectomy don't cause malabsorption of macronutrients, period. They just don't. And so that's a misconception that's been brought forward in the literature, coming from the surgeons who originally invented the jejunal ileal bypass in 1954. And any bypass operation is considered malabsorptive. If you read even this month's issue of Obesity Surgery or SWORD, you'll see that, but it's simply untrue. Now, there's a lot of malabsorption of micronutrients if not managed, primarily B12, vitamin D, calcium, and of course iron. But those can be managed. There's no evidence of sarcopenia after these operations, even the bypass operations, with the possible exception of a biliopancreatic diversion or a duodenal switch, which is a similar type of operation. I want to emphasize that because the misconception about that runs so deep and has been going on so long that I think we need to get beyond that. Now, having said that, even the operations that are malabsorptive, like the old jejunal ileal bypass and the duodenal switch, actually cause patients to eat less. So they don't even work by malabsorption, even when they cause malabsorption. So we should view malabsorption as a side effect, a bad adverse effect of these operations, and we should avoid them at all costs. That is not a mechanism where you're trying to balance malabsorption against. Malabsorption is just bad in these things. And so for a sleeve gastrectomy, clearly very little malabsorption, but there is iron deficiency, there is B12. And get a normal gastric bypass, no sarcopenia. You may see micronutrients.
Can I ask one
As a
follow-up?
comment, we've had some malabsorption of tacrolimus in some of our sleeves.
Different, yeah, so now you're getting into drugs.
And what we've done is we've formulated a sublingual way of taking tacrolimus. And so we've been able to get adequate levels and deal with it in that manner.
Yeah, so you're raising an incredibly important point, which we monitor in all of our transplant patients, regardless of the type of transplant. It is true that you have to, with each operation, we have a new one now, you know, relatively new one, the sleeve gastrectomy, but that has to be monitored, and more work needs to be done. There's variation from patient to patient, and as well as you have to know in that patient, given the tight brackets that you have to put on concentrations of these drugs, what is happening in those patients. And I think we have to do the kinds of things you're describing. We should also know, though, at the same time, that almost nothing is known about pharmacodynamics and pharmacokinetics in people with severe obesity. So you've got a population that selectively has obesity. Forget about liver transplantation, forget about anything. You don't even know what obesity does to many of these drugs because it just hasn't been studied. And so we could be underdosing and overdosing, and not just tacrolimus, but we could also be doing it for all of the drugs we use. And in fact, the University of North Carolina, which is has a big pharmacy school that studies this, is beginning to develop a program just for that issue. So we also have to think about it just for this unique population of liver transplant patients with severe obesity. But I agree with you completely.
Can I want to ask both speakers if, I just want to kind of get this, the sleeve versus the bypass. In a patient who's got cirrhosis, so does it influence the speed of weight loss? So might that be a factor? You know, we were just talking about this worry of rapid weight loss potentially making liver disease more risky, like of decompensation. So is there, like, I also have this sense, and again, that the bypass, they lose weight more quickly. But I don't know if that's backed by any data, and whether you could speak to that.
So the lab study, which is the longitudinal assessment of bariatric surgery sponsored by the NIH, looked at this. And what you see is you get about half the weight loss at 3 months. Or
Regardless of
Now, sleeve gastrectomy causes on average 80% of the weight loss of gastric bypass. And since the curves are in parallel, that means that the rate is also about 80%. So you're not talking about twofold. Now, the other thing that when we started, and we started doing this almost 20 years ago, I was very concerned about this. I was very concerned about fatty liver disease, microsteatosis from rapid weight loss. And we've seen it. We've seen it a few times. Interestingly enough, in every patient except for one, and we've probably only operated on about 3,000 patients, 3,500, but we've seen it in every case. The patient had normal transaminases before the procedure, and then, again, a very small number had a bloom of transaminases. We don't understand that. That's an interesting observation. But the idea that weight loss from surgery is anything like other weight loss is wrong, because weight loss from surgery is physiological. And so you see this rapid weight loss with relative, I can't say absolute, but relative hepatic sparing. You just don't see it. If you did this with a very low-calorie diet, you'd see reliably 10 times the rate of fatty liver disease, including some decompensation. So acute decompensation. So I think there's something about bariatric surgery. It works physiologically. It drives the set point down. That's very different from just simply starving. And what it is that's different, particularly with respect to the liver, we don't understand.
No, I think I would like to add to the comments, totally agree with the rates of drop in weight. Often the bigger challenge is the increased lipolysis. That is the increased delivery of free fatty acids to the liver, and that is probably, so there are case reports as well as personal experiences where patients have gone into what we call as an acute and chronic liver failure, and sometimes they have not been evaluated prior if those kind of surgeries have been done. So that is certainly a big risk factor. In regards to both the sarcopenic obesity and I would slightly differ in the opinion from that point of view, because if you do the body composition studies, there is a concomitant loss in muscle together with the fat. Obviously, the fat loss is substantially higher. So, and when those changes are happening at the loss of fat as well as the muscle, the energetics is switching. It is not making it to be more hypermetabolic. It is trying to attain that homeostasis. And that rate of attaining the homeostasis from increased energy expenditure to the balancing the energy expenditure, that is very variable on each individual. So there is a study that was performed, I think it's only an abstract form, that showed only in 7 patients, but the graphs were all over in terms of energy expenditure, and the muscle losses were very variable. But certainly there was decrease in their skeletal muscle index before and after the bariatric surgery. So that's certainly an area that needs to be further explored. I do not know whether it has any bearing.
I think you're right. I think for the audience, it's important. If you don't do this, what you're hearing is you've got to watch these patients like hawks. I mean, this is not something to do in your spare time. This is something to do with collaboration of bariatric surgeons who know what they're doing, are not worried about, they're not picking an operation based on their experience. They're picking an operation that makes sense, that they can do them all. You have to have hepatology, you have to have obesity medicine, all working, endocrinology, all working together. These patients are so fragile that don't try this at home.
And one of the things I would like to add is also the time point, like the first 4 weeks and then after the 3 months. Somehow, those are the 2 time points anecdotally that we have seen that these patients either crash early or after they've gone by 3 months. What drives that? I do not know, but those are the 2 time points to really watch for. That is why it's very important to monitor them closely, even after 3 months post-surgery.
So in the interest of time, we really need to move on a bit, and then maybe we can take more questions at the very end. So I'd like to thank you all for your
Yeah, thank
attention
you.
and the speakers for their excellent presentations and discussion, and we're going to move on to the next session. Okay?